This is Hans Reamer, Montgomery County Council member, and you're listening to the Conduit Street Podcast, the official podcast of the Maryland Association of Counties.
Hello and welcome to the Conduit Street Podcast. Kevin Kinnally here with Michael Sanderson. Michael, we're back in the office on Conduit Street. It's good to be back in here with you as we record on Thursday, October 1st.
Likewise, happy to be back in the Conduit Street studios. We got the on-air light just outside our glass enclosed and sound protected studios. No, just joking.
One day we will.
One day. That's our aspirational goal is to have like the separate tower just for the podcast.
That's right. Today on the podcast, we're going to continue our look at MACo's 2021 initiatives and explain why these are important to counties. We've already talked, Michael, about broadband. We've talked about elections. Now we're going to talk about another initiative, public health. And these are all very important to counties, but sometimes I think there's a lot more to them than meets the eye. And that's the goal here today. Yeah,
that's what we wanted to do with this short series of podcast offerings, is to sort of dig a little bit deeper into a few of these topics. And the driving question is, why do counties care so much? So if you haven't listened to the last 2 weeks, I'd recommend you do so, because it gives you a frame of reference for what are counties thinking about for the coming legislative session. And we're happy to have Natasha Mehu. She's MACo's legislative director, and she's our lead on health and human services issues. Natasha's joining us today for the podcast to talk about public health.
Yeah, it's so good to see you guys.
Let's get right to it. I mean, local health departments, we have talked about local health departments before and throughout the pandemic. Tell us where things stand now. What are the biggest issues that our local health departments are facing? And you know, where are things?
Yeah. I want anything going on in public health.
Are we dealing with anything?
We'll just put the ball right on the tee for you.
Yeah.
So there's this thing called a pandemic.
Okay. Interesting. Yeah. Tell us about that.
And as the pandemic continues on, at this point, time is just a little bit surreal, but we're months and months in now. But, the health departments are still facing dwindling federal funding to support public health services and pandemic services. We're seeing increase in drug and alcohol deaths. A lot of that also being pinned to some of the challenges that the pandemic brings to being able to treat behavioral health issues. There's no vaccine in sight, or a clear end to the problem. And the flu is on the way. So to say that there are challenges and public health issues that are at the forefront of everyone's minds is probably an understatement.
And I know when we talk about the people, I mean, we talk about local health departments, it's often hard to put a human face, but it has got to be a lot of stress. The staff is dealing with so much right now, doing their daily duties plus the pandemic. I mean, I can't imagine that's an easy thing to undertake at this point.
Right. Because the everyday duties don't stop just because you have a global pandemic happening.
Yeah, that was one of my main takeaways when we had Dr. Polsky, the Calvert County health officer, on just a few weeks ago for round 2 on pandemic discussion. And I don't know, at least half of what he talked to us about was just like the business of public health continues, even when you're in a pandemic and the headlines are about COVID and about masks and about, that sort of thing. You still have drug and alcohol issues. You still have communicable diseases of other sorts. You still have all the other relatively, day-to-day elements of, maintaining a public health front. They're still important, and contact is different and so forth. But anyway, so all that stuff still continues, and in some cases, even worse under these tough times.
Right, exactly.
Right. And then we've also seen telehealth become a buzzword, right? A buzz term during this pandemic. And, I know our local health departments are instrumental in providing those services, but oftentimes, Natasha, it seems like they don't have what they need.
No, yeah. I mean, technology, staffing are also problems that they face.
Okay, so that sets the table. We're in a situation where people are thinking about public health right now more than ever in their lifetime. I think that's probably fair to say. We're just thinking about the public focused health infrastructure more than we ever have for good reason. We're all trying to be good citizens and do the right thing, but we're concerned about our community. We're watching statistics and so forth. So I guess it's no surprise that as county leaders, we're sitting around saying, okay, what of these issues? We got 30 or 40 different things submitted through the county universe of this is what MACo should be focusing on. For public health issues to rise to the top of that list and be on our final adopted list of top issues makes plenty of sense. We want to talk today with that setup of what's behind all this and where do we want to go. I guess the easiest place to start, sadly, is with money stuff and funding on the public health side. It's an unfortunate story how we got to where we are, but that's part of where we are. So can you help us understand a little bit? I guess the core players here, and part of what we want to talk about today, are local health departments. In every county, by state law, there's a local health department with a health officer and staff who are focused on all these issues. So, where do they come from, and how do they keep the lights on?
Right. So, as you said, each county has a local health department, and they are funded through a combination of federal, state, and county funds, as well as fee collections. Usually those federal funds are grants for specific programs. And when we think of fee collection, there may be some fees here and there for certain services, but they're usually provided on a sliding scale, based on income. And so in most cases, fees do not come near to covering the cost of services provided. And
public health is the classic case. Sorry, this is the frustrated former economics teacher in me, but the last thing you want to do is have a really high fee to cover the cost of something like an immunization. Because if that drives people to not get it, then you've frustrated the entire policy goal of getting people immunized.
Right. Exactly.
So keep it cheap, keep barriers low. Public health is a classic case of it's like a common good or a public good where we all benefit by you getting your shots.
The goal is to serve the public.
Right. Exactly.
and protect their health.
Yeah, it's a little different than like a toll road or some of these other good case studies for an economics textbook. This is the counterpoint. So, okay, fair enough.
And we often hear, Natasha, about core funding, and we can talk about this term, but talk about core funding, and we're in this funding conversation. What is core funding? How does it work, and why is it a big deal?
Yeah, so it's one of the most essential parts of funding the health departments. And it's a statutory formula that sets their minimum funding levels from the state. And to do a little bit more clarifying there, it's a state county matching funding program. So counties have the ability to pay a bit more when they need more services to go above and beyond their required match. And counties go above and beyond their required match.
So this is another situation where the state sets the floor and says, if you want to go above this, you can. And we often, most of the time, do.
I think every county, I don't know. It's way in the rearview mirror when that matching requirement was at all relevant for more than the very occasional single county. I don't know. I think of this as the state makes a contribution, but the funding of local health departments has essentially just turned into the counties have to do it. You get something, right? You get a little stipend, right?
Yeah.
Here's a check, and you're like, well, that's a nice start, but we still need to actually serve our public. So it ends up being the county budget picks up an awfully large share of this, and there's a history behind that. Anyway. So the state has a core funding formula. That's how the state does, right? They write a formula, they put it into state law. Here's what it's going to be, and here's what you get. And then every year's budget books have all the details. Here's what your county got compared to last year, blah, blah, blah.
Yeah, and the core funding supports a wide range of services. I mean, dozens of essential public health services that I'm sure everyday people don't even think of all the time. So, we mentioned those communicable diseases, and one way to think of that are those vaccine programs. Public health, those are from your local health departments. Environmental health, where those are your safety inspectors.
Right.
Family health services, adult and geriatric health services, wellness promotion, behavioral health, all of these things fall under services the local health departments provide that are funded by this core funding formula.
And so I like what you said, Michael, about the stipend, right? I mean, we know all of these services are coming through the local health departments, and we know that the counties are contributing a lot of money to keep these services going, even more so during a pandemic. And, the state's chipping in some, and we can get into what's happened over the years that's even diminished that state role even more. But I like that term a lot. And Natasha, as you just mentioned, there are a lot of services that get funded by this core formula. So it's essential that the formula is up to date and it is correct and there's enough money there.
Right. And I mean, one of the things that you mentioned as a component of the way our local health departments are funded is grants. And we know the federal government is notorious for coming up with, here's a grant for this.
Right.
So here's some money, but it's for you to do this specific thing that we want you to do. And sometimes those are very worthy things. We need better data on tobacco cessation. So here's a particular grant to provide these services and track this data. So we have it everywhere. That's great. It's a worthwhile idea, but it doesn't get people the tuberculosis, treatment that they need. It doesn't address these broader public health issues. If you've got someone with a mental health problem, they're not going to be served necessarily by the smoking program over there that's grant funded kind of off to the side.
Right, because grants are very specific.
Yeah.
They're also harder to rely on because because you get a grant one year doesn't mean you're going to get it the next year. So it's, it's helpful funding, but not long-term support for programs that you have to run indefinitely.
Right.
Right. So I mean, core funding, I will say, I hate the term, and I have been frustrated multiple times, and I'm sure you've had the same experience. I mean, we've banged our head into a wall on this from time to time on this, trying to argue for core funding. To me, it's like, well, we need more money for the stapler budget, and and to me, it's like the least compelling part of public health services, even though, I mean, the list of things that you're talking about, I mean, getting people immunizations and helping people who are in a mental hygiene crisis and like trying to serve the elderly population who might need special attention that's above and beyond Medicare and Medicaid or their private providers and so forth. Like, we're doing a ton of that stuff. Everybody would agree that that's important, and none of it shows up in the word core. I hate it. I wish we had a better euphemism or title for that program that a public health inclined person would say, yeah, I want to support that. Core is a rotten word.
Right. And not to mention, I mean, amid the pandemic, remember, these people are safety inspectors, right? They are out there right now. Right. And who is not thinking about public safety when it comes to public health at this moment? So core is a weird term. And Michael, maybe you'll have to see if you can change that. We'll talk later about what we can try and do here, but that might be a component.
I mean, hey, if there's going to be a MACo bill, and we might have some say what's in it. Maybe it's time for a buff up of the terminology, if nothing else.
Right, exactly. Especially to really put a point on just how significant that funding is and how big of a problem it is that, again, to go back to this little money we do from the state as part of the core funding, that's a huge issue for us. The core funding formula, the state share of that, is historically significantly lower than it has been. And this is due to, cost containment and other fiscal cuts years ago. And so when you think of core funding, it had reached its high in 2008, $67 million. We are in 2020, and core funding is just over $60 million.
So we're not even back.
So it's lower than it was in 08. So you're not even keeping up with inflation at this point. You are lower than you were in 08, substantially lower when you factor in how far we are from 2008 and where we should be. So the issue with the core funding is it's been rated and it was never put back into the cupboard. Is that sort of what happened?
It's brutal. We know the routine that Annapolis goes through. And I mean, I think every state government probably goes through its own version of this. We know that when the economy falls apart, and I mean, for those who remember 2008 and the fall of 2008 was the collapse of the stock market, and calendar 2009 was the Great Recession. Mm-hmm. So Fiscal 2009 and 2010 were years of really big belt tightening in Maryland, and the state budget was in real distress. We had lots of people filing for unemployment and added to the Medicaid rolls. We had huge unemployment numbers, big problems with revenues and so forth. So, okay, you've got a short-term crisis. Now, the economy grew back, and we had one of those recessions that you look back as a check mark or a V or a square root sign or something.
V-shaped recovery.
Everybody's got their own variation on what part of the alphabet describes the recovery. But anyway, the economy came back, and piece by piece, the state of Maryland said, okay, it's time to get this back on track. Okay, let's try and get our state employees, recovered from the hardships they suffered at the time. So lots of pieces got cut back. But when it comes to local government stuff, and for the moment, local health departments in particular, we just never got around to it. We just never bothered. And it's weird because it's like no one's out to get local health.
Yeah.
Right? I mean, it's not like there was some sort of policy consensus that this is an undeserving enterprise and it deserves to be cut in half. It just never really made it to the top of the list. And lo and behold, we're here, 3 political generations later. I mean, 3 full terms later, and we're talking about local health as we're almost back to where we were in 2008 in nominal dollars. That doesn't buy you what 2008 dollars did, of course.
Right.
That's crazy. No, I mean, seriously, nobody thought this was a good idea. It just kind of happened.
It's absurd. So when the state came back, when things got better, they started filling in all the holes, and they just stopped when it came to counties, and particularly here, local health departments. They never got that money back that was taken away. And that was never the plan, right? They didn't say, we're going to take this money and we're going to leave it at these levels. It was always, once things get back, just like everything else, we're going to fill in the gap and we'll get you back to where you need to be. But it never happened.
Yeah, so it's just one of those things that I'm sure there are places where the local health departments in each county probably have services they used to provide and can't anymore. And there's probably some places that have said, well, if the state's not going to step up, if that little stipend isn't going to get back to where it was, then we'll fill in the gaps that we can. But sorry, we just, there's only so much we've got to go around. And we lost our funding for our roads department, and we're funding for our jails, and all these other things happened at the same time. So it was a big financial shift between the state and counties. And, 12 years ago is almost like talking about dinosaur times to politicians, but it's still really relevant today.
Right. Because in that time, they had just been forced to do more with less. And then 2020 comes, and suddenly you're in the middle of a global pandemic. And as we said before, they were already doing more with less on their daily duties to deliver immunizations and other healthcare. And now you're in the worst pandemic in fairly modern times since the 1918 flu.
Right.
I mean, I hate to. I mean, I don't want to get political about it, but there's an overtone here of making short-term decisions that have long-term consequences with your budget and with your priorities. And we're a little bit concerned about our federal government. It's like, well, what about the preparedness team that might have had us ready for a pandemic? And, we're leafing through paperwork and documents that say, well, we decided we didn't need that. We didn't fund it anymore. It wasn't important, that sort of thing. Right or wrong decisions at various times in the past, we look back and say, that doesn't seem so great. I mean, here in Maryland, we've been telling public health, get by on a scrimp and save budget for over a decade. And now here we are saying, boy, they're our heroes. They're the ones who are saving our backside. Right. Hope everything's going great. Oh, wait, you never filled that position? Why is that? Well, I'll tell you why.
Right. Okay. So we've talked about money. Michael is all fired up. He's angry.
Yeah, we need a break. Yeah.
We're going to have to take a break. When we come back, we're going to talk about some of the other issues when it comes to local health departments and why they need help, why counties should care. We'll get into all that and more after the break.
This is John Fernay with Ion Annapolis to let you know about our daily news brief podcast. If you want to keep up on Annapolis area local news, local weather, and local events, check us out. We produce episodes every Monday through Friday at 7 a.m. and deliver them right to your phone or computer for free. You can also catch them on our Facebook page, All Annapolis, or under the podcast category at eyeonannapolis.net. You can even ask Alexa to play it for you. So, if you want to keep up to speed on Mayor Buckley, County Executive Pittman, Navy football, maybe you're looking for a weekend thing to do, or if you just want to catch the hyper-local weather, give a listen to the Eye on Annapolis Daily News Brief. We'll see you tomorrow morning.
Welcome back to the Conduit Street Podcast. Kevin Kinnally back here with Michael Sanderson and Natasha Mehu. We are talking about public health. This is going to be a MACo legislative initiative for 2021. As we said earlier, this is part of a series that we're doing to explain why these issues are so important to counties. Michael is back in his chair. He went outside to take a walk. He was fired up on the front half. Did you find that delivery truck that is seemingly just backing up all over Annapolis and beeping?
I got a chance to have a couple conversations about the nature of ambient sound quality in downtown Annapolis. Anyway, it was good. It was an opportunity for me to get rid of some energy that I might have had.
Yeah, you were fired up.
All right, so I'm going to be a better citizen for the back half of the pod.
I will say those sounds are good because it means that recovery is well underway here in Annapolis. These trucks are delivering food and drink to all the restaurants, and so it's good.
I hadn't thought of it that way. Maybe I should go back and talk to them and say, keep on keeping on, guys.
It's good. It's good. Okay, so on the front half, we talked a lot about dollars and why dollars are so important to our local health departments, to health, public health in Maryland. But it's hard sometimes to explain why those dollars matter so much without talking about the people. So let's talk about the people. And Natasha, tell us what the biggest concerns right now are when it comes to local health departments in terms of their staffing, the people that make this happen every single day.
Right. And so, when we talked about core funding and it was like, oh, there's tons of different programs and stuff that falls under this. Similarly, when you're talking about staff, there's a lot of hardworking men and women and that are there helping to deliver all those services. And they are certainly feeling the pressure of the pandemic and also of still doing their daily duties. And so some of the boots on the ground that really feel this pressure are environmental health staff as well as nurses.
Right. And so we often talk about, the heroes of this pandemic. And I don't think people think about your local health departments when we're talking about, these heroes. They all are heroes, but on the front lines. I don't think we often think of our local health departments, but they are absolutely on the front lines, right? Right.
Exactly. Let's take environmental health staff. Mm-hmm. Does anyone know what an environmental health staff person does?
Let's do a quick survey of the podcast listeners. Text us right now. Anyone? Oh, that's right. We don't go live on this. This isn't a YouTube. Okay. So as the audience proxy, I'll step in. Well, gee, Natasha, we don't know exactly what they do. Walk us through it.
These are your safety inspectors. They're the ones who are making sure you're safe in public places. So everything from monitoring the health at the beaches, the public pools, your campgrounds, daycares, mobile parks, reviewing permits and samples of your well water, conducting soil evaluation, going into food restaurants and, making sure that there aren't foodborne outbreaks there, checking your farmers markets, your mobile food trucks, your food vendor deliveries. Those trucks out there are making those noises.
Right.
So I'm hearing a lot of things on that list that, I want to do. My family would like to go to the beach, or I would like to go to a restaurant, or I want to make sure that my family, my extended family who are in senior care are in a safe environment. Like that list of things are things I care a lot about, and I want a good person doing a safety inspection there. So tell me this is working out okay. We're counting on environmental health for all this stuff. All right, now you've got my attention.
Right. And so now that we're in a pandemic, they are also doing, making sure that there are the mask and sanitation requirements that are above and beyond those standard requirements in restaurants and businesses. It's a never-ending job, and unfortunately, given that most people can't tell you who the environmental health specialist is, somewhat thankless, but super important, again, to making sure you are safe and healthy in your everyday activities.
Right. And honestly, I think most of us probably take a lot of this for granted, right? We don't think about it until there is an issue somewhere. If there is a foodborne illness outbreak somewhere, then we start thinking about it. But we take these for granted every single day. But these services are so important in every single way. So I think it really does help to highlight exactly what these people are doing every day and how important it is. Because again, we don't think about it until there's a problem most of the time.
And so our concern here, I guess, is that the staff in this part of the local health department, the people who do environmental health specifically, we're having trouble getting and keeping good qualified people in those jobs.
Right, exactly. It's really hard in normal times to recruit and retain those staff members. They do a lot of work. There's always salary issues and making sure that they're qualified to do the jobs and have the right education and other requirements for it. And so there's a need for environmental health specialists. And I'll also say this is a similar issue with nurses and the public health need. I mean, I think a lot of the times nurses as well as doctors are people that come to mind when you think of public health.
Right.
But when you think that of the wide range of services that are being provided, we keep mentioning they were already working on shoestring budgets with shoestring staff. Yeah. Now these nurses that were providing those health services and immunizations are also being employed to do deployed to do contact tracing and meeting other needs for the pandemic. And so you're really stretching thin some of these boots on the ground workers that already had important jobs.
One observation, I don't want to get super into the weeds about legislative process and components of bills and so forth, but as we think about most of these employees, the bulk of them are in the state employee system. So like the job of environmental specialist 1 is sort of classified in some manual at the state of Maryland level that says this is a whatever, this is a grade 11 position and the pay range is X to Y. So in theory, the state, this isn't as simple as, well, hey, if Dr. Polsky and his team in Calvert County wanna get more, get more good work done by their environmental specialists, just go out and pay them more. That's easier said than done. As a practical matter, that job is classified by the state. There may be a role for the state to have some say into how do we treat that job, what are the expectations, qualifications, and where do we classify it. So we kind of like let's put a pin in that as we think about this as a legislative issue instead of just like our moans and gripe session, right?
Yeah.
Right. And that's often an issue. We talk about this in a lot of different fields when it comes to government versus the private sector. Government often does have a hard time hanging on to really good people because the private sector can come in with more money. So yeah, I think that's a big part of this conversation moving forward, right?
If you got the qualifications to be an environmental specialist 1, then somebody's going to hire you away to say, actually, we've got a much better job for you.
Exactly.
Right. That's exactly what they're saying.
That's what happens. So, I mean, Natasha, we talked last week about broadband. That's also going to be a focus for MACo in 2021. And we know that technology continues to be a pressing issue in many ways. How is it impacting health departments?
Yeah, I mean, what doesn't technology touch, or broadband for that matter? Yeah. I think one of the biggest issues when you think of public health today is telehealth, and the pandemic might have really put the spotlight on this. But telehealth is something that has kind of been growing in recent years. And in case there's anyone that doesn't know what telehealth is, but it's essentially the ability to receive some health and treatment from a healthcare provider via, your computer, your phone, just not in person. So you don't have to go to the doctor's office. But in order to do that, you're going to need, your computer is going to need to be connected to broadband or other supportive technology services. You have to have that computer to do it. And so, what part of the pandemic highlighted was just the need to make that sort of treatment more accessible. And if we take away the pandemic, you could also think about this in terms of people that live in rural areas or places where there aren't a lot of providers there. And so in order to expand your access to treatment without you having to drive miles and miles and miles and miles to get to a provider, telehealth serves that sort of purpose.
Right. I will say, as a side note, but as sort of an accompaniment to that, I thought some of the most interesting content we had during MACo's summer series, where we did a series of sessions on different topics of the day, some of which we built with our professional affiliates and so forth, and some of which were brought by our corporate partners and others who are stakeholders in MACo's success. The discussions about telehealth, I thought, were super interesting and really eye-opening for me. I just had my first annual physical done by telehealth just a few weeks ago, and it was an eye-opening experience. I mean, listening to a session talking about it, and teledentistry, by the way, it never occurred to me that could be a thing, and that totally made sense to me as a thing. But my physical, I got a bunch of stuff in the mail. I'm going to get blood tests. My doctor easily could have been in Portugal, right? And it would have worked out basically just as well. I'm lucky to live in a neighborhood where I've got a good broadband connection, and I'm lucky to have the ability, the ability to stream video, so I could send my doctor a couple of things. But basically, I don't know. I can see how this fits at the private sector level, but also in public health as well. We're trying to fill gaps, and if this is one way to do that, yeah.
And Natasha, you mentioned how beneficial this can be for people who don't live close to a facility where they can get this treatment, often in rural areas. And we know that lack of broadband affects every county. It's not just a rural issue, but it's really a double whammy, right? If you live far away from a facility and you don't have access to high-speed internet, you're really stuck. You don't have telehealth capabilities, and you also are now going to have to drive a very long way to see a health professional. So that really is a double whammy when it comes to rural telehealth, especially, right?
Right. And, telehealth isn't the only technology-related issue that the health departments face. In a lot of ways, when we think about public health systems, not only in Maryland, but broadly, is that they're really working on older sort of technologies. So fax machines are incredibly important to doctors' offices and health departments. Hold on.
What?
We're talking about fax machines?
Faxes. We talk about faxes?
Right. What's really
seriously, they're honestly like sending information from place to place by fax machine, and someone's handwriting, or it goes into a paper folder or something?
There are a lot of, laws on privacy, and it wasn't until, the passing of the Affordable Care Act that electronic health records started to, have more of a push for that. And so really, in a lot of these cases, you're still kind of dealing with some of the more outdated technology. And, I keep bringing up the pandemic, but it's just in front of our faces. But, you're seeing now with all these dashboards of information, but in order to share that, to get that information out into the public, you also have to be able to share between health department to health department, to the state, to the federal government. And so there's to the doctor's offices. When you think about the amount of information being shared and outdated systems to do so, it's just another area in which you're a little bit behind.
I guess I'm trying to put two and two here together. I never heard anybody say this before, but this is the stuff that happens when you go for a decade or more on a scrimp and save budget. Right? We talked, a little while ago in the first half about the state funding hasn't even caught up in nominal dollars to where we were 12 or 14 years ago. So if your local health department has said, we're doing all we can with way fewer dollars than before, what do we cut back on? Do we say, let's just not give flu shots this year? Or do you say, let's just try and get another year out of the fax machine? Right. You make a human decision, right? You're trying to run the local health department. Number one is let's serve the public. And we've got people who are sick and needy and need care. So we prioritize care. And that means we might not be able to fill that extra position who does clerical work. We might not be able to get the technology to have a better database to share our information with the state. Sorry about that. Something had to go.
Right. And when it comes to modern health records and, the new technology, we all have a cell phone, right? And let's say there's a new operating system. You want to download it, but you get a message that, in order to get this, you need to have have like the cell phone that was available 5 years ago. You're still using one from 8 years ago.
Right.
So you can't even download this new software on your phone because it's so old. It seems to me if you don't have the infrastructure at the local health department, even if this new technology is available, you're not able to connect to it because your equipment, your devices are so old that you have to upgrade to be able to use the new technology.
We're talking about faxes.
Faxes. We're talking about faxes. And I think a lot of people would be surprised to think, we oftentimes think of healthcare as becoming more modern and we have these digital records, but we're still using fax machines. I think that is really, really important to understand and to understand what our local health departments are dealing with and what this cut essentially has meant for them over the years, and that they really do need to upgrade their technology so they can use the latest and greatest technology and keep records safe and make sure that people have all the latest and greatest when it comes to public health.
So far, I mean, we've focused on the sort of the state funding relationship to local health departments. And so far, like our setting, if this is a sitcom, all of our visuals have been, we're here at the building and has written right across of it, county health department. And it sounds like all of public health is happening within the building. And they've got their, one person with a phone and they got a few people running the fax machines apparently. But I guess that's not really the only setting where we're doing public health. So as counties are thinking about public health as a priority, there's more than just the stuff inside that building, right?
Right. When we're talking about public health, when we're talking about this initiative, we're really talking about public health wherever it happens. So we're also talking about fire and EMS services, the health that's occurring when you're calling 911 to have someone transport you, or you need kidney dialysis because you don't have a car. And so there needs to be some sort of county transport support that goes out and helps you. You're having an overdose and, our folks come and they're administering naloxone to you. These are all areas in which health services are being provided by county government and our agencies, and in many ways, all of these areas are behind the times and in need of funding and support.
I think that's true, and it's an evolution of our ability to serve. It's a smart thing. Over time, we have gotten our EMS staff, emergency medical technicians, and the trained staff who respond to the majority of our fire calls, right? We still talk about fire departments, but you run the numbers and it's like 80% of calls to fire departments are basically emergency medical calls. We still have buildings catch on fire. It does happen. But when we say fire and EMS, it's EMS and fire. So, but we know that this is part of public health, and we've got a lot of laws that are still written around emergency transport. If you're having a heart palpitation and you dial 911 and an ambulance comes out and picks you up and brings you to a place and you get treatment there, then the delivery to that place is an event that somebody like Medicare would recognize as treatment.
Yes.
But increasingly, we've got trained people who say we don't have time or we don't need to bring the person to the hospital because we can treat right here. Right. And they've got, and that's a good thing.
Exactly. And a big example of that is, as I mentioned, naloxone and overdoses. A lot of times EMS gets called out for an overdose. Naloxone's delivered. The person wakes up. The person says, I don't want to be transported to the hospital. But the EMS staff still came out. They still delivered treatment. They still helped that person. And in that case, because there was no transport to a hospital, Medicaid, Medicare, none of that is reimbursed.
Nothing happened.
Which is absurd.
Yeah. No one was in the hospital and nobody got an emergency ride in an ambulance, and therefore nothing happened as far as they're concerned. That's just a dumb law.
Wipe it from the books. Right? It just doesn't make any sense. Right? It doesn't make any sense. Then I think that's a great example of how far behind the times we are, not only when it comes to the technology and the funding, but also just the laws on the books. And a lot of that is Congress, and we know what Congress can't get done. They can't do anything. So I don't know what we can expect there. But Natasha, how can we move forward? We've talked a lot about the issues with the funding and with the people and with we need resources to keep things going, especially amidst the pandemic. We need to get to where we need to be. What can we do to move the ball forward?
Yeah. I mean, I think one of the bottom lines here is the funding overall for health departments and some of these laws. You can't think what was good in 2008 or decades ago is sufficient now for providing these essential services and care. So it still comes down to those three areas of primary focus: the funding, whether the core funding, the support for various services that are provided, staffing, incentivizing that recruitment and retention of those key staff professionals, and technology, making sure they have the technology and tools on hand to be able to perform their duties.
So those are really the three pillars of MACo's push in the 2021 session: funding, staffing, and technology.
So, I mean, there's a variety of ways you can label this. It's a little bit of catch up. It's a little bit of modernizing, and it's probably patching over some things that we should have been doing years ago. But you bundle that stuff together with that list of services that you ticked off earlier as to what the core duties of a local health department are. I just have to feel like when we put together, what MACo usually does is on our big thing, we're going to have a bill. We have a one piece of paper that says, here's what the elements of MACo's bill are going to be, or here's a 6-page draft of the bill or whatever. We start walking that around to policymakers. I think it's going to attract a lot of attention, right?
I think this is one that everybody's going to want to be a part of. I think you'll have that sheet that Natasha will be walking around with to get co-sponsors, and it will be filled up with all different colors of ink, and everybody's going to want to
Don't leave yet. I want on that too.
Right.
I overheard what you were saying to her. I want to be on that bill too. Right. I mean, I think this is that kind of subject. I hope so, but I think so. I think it should lay out that way, that let's be prepared for the next thing that happens. Let's not make the same mistake twice. And let's make sure the next 24 months we've done all we could. I mean, yes, and yes.
Yes.
And we know, this pandemic has been awful in so many ways, but this is another example, I think, of where the pandemic has really shown everyone the importance of our local health departments, and it's brought them to the forefront. And maybe we can take advantage of that and make sure that these folks have what they need to do everything that they do every single day to keep us safe. So makes a lot of sense to me. And thank you so much, Natasha, for coming on and walking us through this focus for MACo in 2021.
Always a pleasure, guys.
We'll be working on it.
All right. We'll go ahead and leave it there for today. As always, if you enjoy the podcast, please go ahead and subscribe. That way, all of these episodes will be sent directly to the device of your choice. Of course, you can also follow along on social media, Facebook, Twitter, and of course, the Conduit Street blog. But for Natasha and Michael, this is Kevin signing off, and we will talk to you soon.